Okay, so I'm AJ, and today we're talking about Haley Holmes. So she's a 49-year-old Caucasian woman who presented to our GP with joint pain and fatigue. She had elevated serum ferritin levels, which means there's high iron in her body, and that was at a checkup 12 months prior. And she had her joint tenderness was confirmed, and she had mild hepatomegaly, and her BMI was normal, and she had limited alcohol consumption. But with all those symptoms, the doctor suspected it might be hereditary hemochromatosis and ordered a fasting blood specimen.
So what is HH? Hereditary hemochromatosis is a genetic disorder that can cause severe liver disease and alcohol intolerance. It is a disorder that causes the body to absorb too much iron. The typical clinical signs include cardiomyopathy, diabetes mellitus, endocrine dysfunction, and liver damage. These manifest as early symptoms such as joint pain, abdominal pain around the liver, and pancreas, which Haley was exhibiting. These symptoms and their severity are affected by lifestyle factors and presents earlier in males as they have no way to excrete the excess iron, whereas women present after starting menopause due to the menstruation no longer occurring. HH tends to be underdiagnosed partly because its symptoms are similar to those caused by a range of other illnesses. This underdiagnosis may result from the lack of awareness of the disease, its long latency period, and its non-specific symptoms. Haley had no pre-existing conditions. There was no alcohol abuse to explain the high GGT levels. As HH is an autosomal recessive inheritance pattern, her children will also need to be tested. Otherwise, Haley had healthy BMI and was in good condition otherwise. Based on her medical history, the next steps would be to determine if her iron overload is a result of increased hemoglobin levels. Given that her blood levels were elevated, we also need to do a serum iron test to see if there had been any changes within the last 12 months. We will then analyze these results and determine whether we can diagnose Haley or will further testing be needed. Hemoglobin was analyzed using the sign metaglobin method. As per this process, the important thing to note is that a standard and a control was used to calculate the HB levels. Ferritin levels are the most specific indicator for HH, as it only tells us about the stored iron.
For diagnosis of hereditary hemochromatosis, transferrin saturation and ferritin levels must be looked up. Transferrin saturation indicates the iron transporting protein circulating throughout the body. The normal range is 15 to 50%, and anything above 50% indicates that there is too much iron circulating throughout the body, which may lead to tissue iron overload. To test for tissue iron overload, serum ferritin levels are observed. Serum ferritin reflects the total iron stores, which increase in the progression of hereditary hemochromatosis. If a patient has a serum ferritin level around 200 to 300 or anything above, this means that this supports the diagnosis of hereditary hemochromatosis. While these tests are effective in indicating whether a patient has tissue iron overload, they are not a definitive diagnosis of hereditary hemochromatosis, and genotyping such as HFE mutation testing must be done. It is also important to note that a liver biopsy is not recommended for the diagnosis of hereditary hemochromatosis due to the effectiveness of HFE mutation testing and the invasiveness of the procedure. If liver function does not return to normal over time, then we may recommend a liver biopsy. And to see which patients may benefit from a liver biopsy, serum ferritin levels can be observed. If a patient's serum ferritin level is over 1,000 micrograms per liter, they have an increased chance of cirrhosis and would definitely benefit from a liver biopsy. In the absence of excessive alcohol intake, and if a patient's serum ferritin level is under 1,000 micrograms per liter, this means they do not have an increased chance of cirrhosis and do not benefit from a liver biopsy.
So here's the blood test results that we were provided. So after the 12 months from a previous ferritin measurement, she still has a very elevated ferritin. and we look at our liver function markers, ALT, AST, and GGT, and she has extremely elevated AST and ALT activity levels. So this indicates that there is stress in the liver, and this stress could be because of iron depositing, because her body has too much iron. So for the hemoglobin estimation, we use the Draken's method. So we had patient control and standard samples that we diluted in Draken's reagent, and then we measured the absorbance in a spectrophotometer. So here are the results. So using this equation with the absorbance, we managed to get concentration in grams per liter, and she had a concentration of 143 grams per liter. The healthy level is 120 to 160 grams per liter. So clearly she has normal hemoglobin levels. And the importance of this test is that some people have naturally higher hemoglobin levels. So it's important to note whether she has too much iron because her body just needs more iron. In this case, she has normal hemoglobin, so the high serum iron levels are due to like an underlying issue. And the control is in range, so we accept the results. For the serum iron test, we use the ferrozine method. So on a microtiter plate, we set up 4 columns and we did it in triplicate with rows A, B, and C. We added iron reagent, an iron buffer, to all the wells, and we measured initial absorbance. And then we incubated for 10 minutes while we added an iron color reagent, and then incubated for 10 minutes, and that change of absorbance allowed us to calculate using the equation below the micromoles per liter concentration. So the concentration she had for serum iron was 39 micromoles per liter, and the healthy level was 10 to 30 micromoles per liter. So she definitely has elevated serum iron, and the control is in range, so we validated these results. Transferrin is our body's circulating iron carrier protein. So we calculating the percent saturation of transferrin using UIBC, the unsaturated iron binding capacity that we were provided with in the table from before, the blood test table, which was 14.5 micromoles per liter. And that just measures how much transferrin is in binding to iron, essentially. So using this equation below with the serum iron concentration, UIBC, we found that she had 72.9% transferrin saturation, and the healthy level is 15 to 50, or like 20 to 60 roughly. Different sources say different things. So she has iron overload, and the deposition of iron into vital organs is very likely. Next we did PCR-FLP genotyping. This is our final test. So we did PCR with a prime pair targeting exons 2 and 4 of the HFE gene. And then we did a restriction digest of MBO1 and RSA1 and an agarose gel analysis to see if we could actually visualize whether mutations were present. So it's important to note that a negative result in this specific test doesn't mean she doesn't have hemochromatosis, because we're only analyzing HFE, and there are other types. There's type 2, which is juvenile, that involves HJD and HAMP genes, and then there's type 3, which involves the defective transferrin receptor. So yeah, negative result doesn't mean she doesn't have it, but we can confirm it if we have a positive result. So looking at the exon 2 MBO1 digest, we're looking for a H63D mutation. So H63D destroys a mutation site that naturally exists within this amplicon. So instead of getting 2 fragments, we just get the 1 fragment, which is the size of the amplicon. So here's our band pattern table. We have wild types, so 2 wild type copies, no mutations. We get 2 bands, and that's just the size of the broken down amplicon. For heterozygous, we get 3 bands, so that mutated copy gives us an extra band, that's the size of the amplicon. And for a homozygous mutation, 2 mutant copies, we just get 1 band, the size of the amplicon. For the exon 4 RSA1 digest, it's a bit more complicated. So we're looking for a C2A2Y mutation, which adds an extra RSA1 restriction site within the amplicon. So instead of getting this breakdown into 2 fragments, the amplicon is broken down into 3 fragments. So for wild type, we have 2 bands. For heterozygous, we have these 4 bands because of the extra 2 tiny fragments. And then for the homozygous, 2 mutant copies, we have 3 bands. Because there's no small fragment anymore, because both copies have that mutation and were completely digested into the 2 tiny fragments. So here's our job. We have our blank, no DNA, no enzyme, negative control lane 1. Lane 5 is our DNA base pair ladder. And then we have duplicates, so P1 and P2 on both sides of the ladder. We have a control with exon 4 and exon 2 labeled. This is just our DNA, no enzymes in these lanes. And then we have our MBO1 and RSA1. restriction like digest. So for MBO1, you can see 2 bands that are attributable to exon 2. So this means that she doesn't have a H63D mutation, she has just wild type exon 2. For RSA1 though, you can see 3 bands with these arrows, because it's kind of hard to see through the poly. She has 3 bands for exon 4, and that means she is homozygous for C2A2Y, which means we can diagnose her with type 1 hereditary hemochromatosis.
There is no cure for hereditary hemochromatosis, so we must minimize the amount of red blood cells circulating throughout the body. In the management of HH, bloodletting is the most widely accepted treatment. It is a simple procedure and involves repeatedly drawing blood from the patient once or twice a week until the iron levels have returned to normal. This reduces the iron in the hemoglobin and stimulates erythropoiesis, which releases stored iron. Once the iron levels have stabilized, it is important Haley comes back and gets bloodletting 3 to 4 times a year to continue to make sure her iron levels remain stabilized. Additional measures to minimize the effects of HH include dietary modifications. Hepcidin deficiency is attributed to mutations in the HFE complex. Hepcidin is a peptide produced in the liver which regulates iron homeostasis. Due to dysfunctional hepcidin in patients with HH, dietary iron is absorbed in excess. Therefore, maintaining a diet that avoids iron-enriched foods is optimal. Ideally, a vegetarian diet would be best for Haley, and it is vital she also completely stops drinking alcohol, as this will accelerate the damage to her already strained liver. It is also really important that we genotype Haley's daughters, as HH is an autosomal recessive illness. HH is also HH is a common disorder within populations of European ancestry. As Australia is a predominantly Caucasian country, there is probably a large number of people with undiagnosed HH. Due to the nature of the symptoms, HH is commonly underdiagnosed and has caused severe damage or associated diseases such as fibrosis, cirrhosis, or liver failure. Population screening, despite the costs, supplies, and other negative factors, would ensure the early diagnosis of this disease would be increased. For patients such as Haley with such common symptoms, hereditary hemochromatosis would be caught early before advanced issues arise. This would provide less strain on the healthcare system to provide liver transplants. At the very least, it is very important that we population screen those with hereditary hemochromatosis in their families, as this will indicate whether they have the mutation or a carrier of the disease.
Questions?
Questions?
Questions from the audience?
All right. So you told me that this is an iron overload disorder. You told me that there's different types of iron, testicular, transferrin, and ferritin, and all that jazz. How is HH an iron overload disorder? What does a mutant HFE do? You were sort of touching on it a little bit.
Yeah, so HFE regulates hepcidin, which is a protein that essentially regulates how much dietary iron is actually being absorbed into the body. So with the mutation in that pathway, you just get basically unregulated absorption of dietary iron. And because there's no way to metabolize iron, it just has to be let out through the blood. This is really dangerous because you just get built up of iron. And it's a genetic disease, so it's not like the body fixes itself or anything. That's why, yeah.
Just circling back to question 8, I think. Did you outline the diagnostic strategy?
Yeah, like our test.
And then you said that little
Well, it depends what stage, but it's really invasive, so you don't want to do it.
what would you be wanting to see?
Probably
So with this disease, you get an increased chance of fibrosis, cirrhosis, or liver failure. So it's only if their serum ferritin levels have returned to normal after a period of time, but not to diagnose the disease.
Is there anything else that is susceptible to anemia with iron overload?
You guys have any answers?
Needs to be very good for cancer.
Yeah, I was gonna say that.
Yes, huh?
Yeah, I guess I can start.
Have any questions go first? I forgot what I was about to ask, but you go.
I'd like perhaps to, I probably mentioned it briefly, but can you elaborate on the physiology of the proteins that are coded for by the genes affected here?
So HFE encodes for hepcidin, I believe, and hepcidin has a role in, I think, binding to epithelial cells. Blanking a bit. Basically, when iron is absorbed through those cells, there's a whole process of changing their oxidation state and getting them actually into the blood. And hepcidin plays a role in regulating whether they will go into the blood or they won't, essentially. And that's all I can give you. George?
So, yeah, I just had a question about the RFLP assays that
Yeah.
you've done. You've got two different assays for two different potential alleles. Yeah. The H63D and C282Y.
Yeah.
In one of the cases, the fragment pattern could look like a heterozygous, but it's actually homozygous.
Wait. Are you talking about this?
Yeah, so if you're actually looking at your RSA1 assay, it's actually a really good assay because irrespective of the actual allele we have present, you should get a fragment pattern. But if and you should get a complete fragment pattern that's different from the uncut bands. Whereas for the other one, it's possible to have uncut band present.
I also wanted to mention, it might be a bit confusing because here we say that exon 2 is broken down completely, which it is into these two bands, but this looks like it's migrated, and that's because exon 4 also has an MBO1 restriction site towards the end of it, so it loses a bit of length in the MBO1 restriction, and that's where it migrates a bit, but that is exon 4. So in this lane, it's not like 3 bands from exon 2 or anything. That's exon 4 still. Same with in this one, we have exon 2. This is from exon 4. It's one of the fragments.
Okay.
It's smaller than that one.
So can I ask you, so this is related to this question. If in lane 3 you were to get a band at the size of exon 4, what would that be telling you about your assay?
That was probably contamination or maybe like...
Not contamination.
Complete opposite.
Yeah, can you rephrase the question real quick?
So it's great that you said that, because in lane 3 you now have those 3 bands that are different from the exon 4 and the exon 2 uncut bands. But if you were to have a band at the same size as exon 4 in lane 3, what would that be telling you about your assay?
I guess maybe there's some exon 4 that's undigested.
Yes, and so what would that mean, perhaps?
That we did it wrong.
It might mean you didn't have enough restriction enzyme in the sample because you've got one of those reactions has a logic completion.
Yeah.
And that's an important thing because particularly in the other assay, you may actually misdiagnose a homozygous or a heterozygous if you don't have full completion, you don't have complete digestion of your exon.
Yeah.
Because you're relying on that to happen in order for you to get the genetic diagnosis of a homozygous. So
And that's important because this is the only way to diagnose.
Could you tell me another way you might be able to genotype these people?
I mean, besides like genotyping for other types of,
Just,
just type 1.
Another way other than doing an RFLP is the RFLP assay. an extension question, but I don't.
That's beyond my
We
take.
did
Yeah.
talk about it, we did talk about it. I said if you want to confirm something like this is like a pretty quick and dirty way of doing it.
Right, yeah.
Pretty like cheap, dirty way. As you said, there can be partial digestion if you don't saturate with the restriction enzyme. There is a next step, there's a cleaner, nicer way. For example, how would you screen the population? You can still do saliva and DNA extractions, then what would you do with the samples?
You can just sequence the
Sequence it.
yeah.
Oh, right, yeah.
Yeah.
Like with a little microchip or whatever.
Oh, what?
A little chip, you know, like in the wild, like samples.
Yeah.
I'm only asking these questions because you explained this thing very well. So,
Yeah, you did. More attention.
Yeah, I was gonna-
Definitely, everything was tips, so you answered all the. We just want to see you cry.
I was gonna go into like the base pairs and stuff, but like there's so much like info. Like you guys you don't need like the numbers, you just need like big, small explanation, context and stuff.
Mm.
That's just a lot to explain every single like reason. But I really nice.
No, it's
No,
great.
that's really
That's exactly
nice.
what you want to see.
That's
That's
really
good,
nice.
yeah.
Thank you so much.
Thanks.
Okay. So overall feedback, you all spoke very nicely, it was really good, very clear presentation. The way that you broke this down and told me what I'm looking for before showing me, because the gel isn't the clearest thing to look at, but telling me, hey, if we're looking for these size things, I'm going to sort of going to show you it here, it was really good. I don't like, the white on the purple is okay, but the red on the purple, I'm
Yeah.
seeing, so read that.
Wait, which red? Oh, at the beginning.
No,
There's
down
a
the
couple
bottom.
of, you have like some red and I'm like, oh,
It's a
I
lot
can't read
better
that.
on the laptop.
Yeah, sorry. No, that's okay. I think at the start you had a couple of busier slides. Oh, the blood test one, you had just like a million
The whole
numbers
thing.
there, but you did highlight.
Yeah, that's what I was going.
But did you have to show me the rest of that picture? Could you have said we tested
Yeah.
a lot of other blood things, they were all normal, so we excluded them, so, but these are the ones that
Yeah.
highlighted some important things, maybe just for reference.
Like to crop it out.
Yeah, one issue I did have, you did talk about, you showed some raw data. So like you showed raw absorbance values, you don't need to show them, you can just tell me what the final number is. I understand for a presentation like this, you're saying, look, things are in range, we did everything properly sort of thing, after it's a good, but just making sure for your report, don't show any raw data.
Right.
You can just show me the final numbers, tell me the controls are in range, and you can accept it sort of thing. I actually really liked that you took me through some of the methods, and you told me absolutely everything I needed to know within time. That's like a really important skill. You told me everything, you took me through a gel, you answered all 10 questions within time, and you still took me through the method of how you did things. So that was really, really well done. Yeah, I just couldn't read any red on the slides. But the white on the darker background worked fine for me. I thought overall your slides were quite nice. 1, 2, 3, 3.
Oh, no.
That actually says 4 if you look closely.
Sorry.
No. Yeah, no, it was good. It's good. Oh, I have one issue at the start. You just had like your slide, and you were talking and telling me all of her patient information, and I was waiting for you to click to a slide with the patient information, and then there was nothing.
Yeah.
So just for next time, if you're talking about something, do have a slide about it. So just an intro slide with a few dot points of her history would have been good. But overall, it was very well done. You got a lot of information.
And if you just go back to that slide you had there before, just, no, next slide. Okay, there's a little zeros here that's come across from somewhere.
What?
Oh,
That's
yeah, it's like
just
a
a picture.
little.
Oh,
No, on the next slide though, it's confusing because
Yeah.
it's
Yeah.
kind of right next to
Yeah,
that.
yeah.
You just have to be careful of those little things, not that it matters at all, but those sort of things are just weird, like, and sometimes you might have, like you've got an equation and you've got a plus and a zero next to all the
Yeah. Nice. Oh, Andrew?
Yeah, I thought that you did a very good job. Rehearsing most likely you did well, and the timing was good. You included most of what we expected on the presentation. I would have liked to have more on the physiology of the
Yeah.
hepcidin and why is that. So how come you get high level of iron when this is happening? This is the core of the case study. So that would be desirable. But otherwise, I thought that you did a very good job at presenting. The flow was fine. Except at the beginning, you were discussing the ion tests. You did that first, and then you came back at that again. So that was a little of repetition in there. So but overall, I thought the quality of the slides was very good. Exceptionally well done. The explanation of the PCR and the gel, I thought it came across very clearly.
So I concur with what everyone else has said. A couple of things for me. I also think that very, very careful. Never put red on a kind of dark background. Even on black, it's not great, but on purple, it's terrible. And the only other thing I just wanted to say, just be careful with the tense that you use. You know, because you were talking about what we're going to do, and then you said what we did do, sort of a bit interchangeably. When you present a case study, it's really good to present it in the past tense. You can talk about what the person presented with and everything, and then talk about it in the past tense. We did this because of this, or whatever not. We should do this. And that was one thing, just to note, I think.
It's important for your reports.
It's just
Yeah.
important to be
Past tense,
consistent there with that sort of thing.
Did you have a problem with the way I talked about mutations? Because I know some people
Major
think
problem with it.
like when you say like a mutation's introduced, but she's had it her whole life, but you use the terminology like the mutation's introduced.
Well, in reality, a mutation is something that happens,
Yeah,
and an allele exists. So mutation is actually an event.
Yeah.
But it's used interchangeably in science, but that is pedantic as
I was worried by saying introduce. You guys
The
would
mutation, so the mutation occurs sometime and then it exists. The sequence
Yeah.
of
You
years.
were talking about the introduction of a mutation compared to a wild type, so I was okay with the way that you had explained it, but
Okay.
here's the genetics.
Yeah, I mean, it's a pedantic point, but I wouldn't have worried. I didn't have a problem with it.
Yeah.
We weren't deeply affected
I don't
by
have
it.
a
so
problem because
go sit
a
down.
lot of genetics actually use that sort of terminology. But it is important just to remember that if this is just a variant of the gene, or you're studying two different variants of the gene,
Yeah.
the HFE gene.
I
Oh,
didn't really
sorry.
have anything to add, to be honest. I just really liked the science and I thought the information was great. It was like my favorite part, quite frankly. Very nice.
Cool.
And the explanation of Jill again is beautiful.
Oh, just one negative. Jacinta got a thanks, but I didn't get a thanks. So that's just like minus one. So no thanks.
Thank
It's
you,
Jessica. So they get a minus one. They get plus
And
one.
neither did I, by the
Yeah.
way.
Yeah.
But anyway,
Thank you
All right,
very
thank you very
much.
much.